don't scan feet and ankles with it on the table because I need to be able to move it and go around it and all that. So the fact is we're gonna, well, let's just move the table if we can. There we go. No, that's fine. Just back is fine. That's good. That's good. Yeah, because they're not gonna be able to see too much. Okay. Alright, so on his back with his head off the there, with his feet off the ends. There, that's good. Maybe poquito más. A little bit. That's perfect. Okay, I'll go to my Spanish. Okay. Alright, get this laptop out of my pocket. Okay, so I just want you to realize when you're doing an ankle that all the tendons in the side are under the tibia and the fibula, and so they're not easy to find. So I'm going to go through the protocol. So I'm going to do the anterior compartment first, then I'm going to do the lateral compartment second, then I'm going to do the medial compartment third, and then I'll end up with the posterior compartment with the Achilles tendon and all that, unless I run out of time. But I'll try and move quickly. So I think I can sit down. Got it. Okay. Let's see which one's going to be a good one. They can probably see that.
This one is good one. That one is a surgical.
Surgical one. Oh, that'll be entertaining. Okay. Yeah, so I'll take some gel. Always important to have gel. And remember, with my group, everybody's heard over and over again for the last 2 days from my group, is I don't put gel on the probe. I put gel on the patient, and I get the gel off the probe or off the patient to use with the probe. So in other words, I clean the area, I put the gel in the clean area, and then I go get the gel when I need it. Because I don't want it on my fingers, because if I got the gloves on, I can't hardly hold the probe. So I wanted to avoid that. And then remind me, I want to turn the lights on once in a while so they can see the probe angle. No, not now. No. Okay. So I need more gain, please. And then if you'll tilt the screen toward me, down, tilt the screen down. There we go. And more gain, please. Okay. And so what I'm doing is construction back there. Okay, so the first thing I'm going to...
We can see the camera imaging is go to right side maybe.
Yeah, you're talking about the video?
Video.
Yeah. The problem is he's got a surgical ankle on that side. Okay, let's, that's not going to help because I'm on this side of the
方向的问题是大小相机可以绕转，
不是，就是你的相机要对着。
相机本体
那对上去。
I understand the discussion now, but I didn't know I didn't understand before. Okay. Here's my hand. All right. Well, I'll scan with this hand then. All right. So I need that facing me so I can see it, the screen. Can I? Thank you. Okay. So the first thing I'm going to do is I'm going to go turn the tib fib joint, and then what I'll do is I'm going to slide the probe down until I can see the. And I'm going to go about 30 degrees with the probe, and then that's going to give me the syndesmosis between his tib and his fib. And so right there is the syndesmosis between the two. So that's going to be the syndesmosis. And now you can see why they have a high ankle sprain, because you're gonna see, as I go caudally, you'll see the talus go right through. So right through is gonna be talus. Yeah, you know what, can I have a paper towel? We need another model. He's got a surgical ankle and he's got a sprained ankle.
再来一位，
There you go.
再来一位 OK， 所以我们可以
To show you what a normal one would look like, he's already had a high ankle sprain. Off the table a little bit, a little farther. There you go. Perfect. Okay.
第一样呢要注意呢，就是 scanning 呢，把那个脚呢整个呢，在床尾那边整个可以凸出来。
So there's the ligament all the way across. And now I'm going to slide, when I slide down, you should see that the navicular is going to come right through it. So there's navicular. So you can explain that, or that stand.
OK，它就是像脚趾头那边呢，一直 scanning 的时候呢，就下面那个 talus 会跑出来。
Probably what I should is be able to watch you too. All right, and then you see the talus come through.
然后你看到 talus 就它的 cartilage 有它的 cartilage 会跑出来哦。
And then when I go to the anterior compartment, I'm going to go to the posterior tibialis first. I'll turn the probe on the posterior tibialis, and then I'm going to
Tibialis anterior 应该是。
into anterior tibialis, and then I'm going to just follow it along. But the main thing here is a hip freeze, and then show them where the injection would be.
这个 cartilage 在这里，然后我们这边呢，这是 fat pad。injection 的 target 的话呢，是在这个 fat pad 下面。哦，你如果你这边如果要从这边进来的话呢，进针要到下面的话呢，你要用一点 short axis， 但是就是 outer plank， 但是一点点的 lead approach， 但是你不要打到它那个 cartilage 上面，那个 sub 上。
So part of what I'm going to say, and hopefully you'll repeat, is if I have the tendon and long axis under the probe, when I put a needle next to the probe, I'm not going to go through the tendon because I know the tendon's under the probe. The other part of this is when you get the needle under the tibia, you don't want to hit the cartilage on the talus, but what you want to do is go under that because that whole triangle of fat should raise up in the air. It should, the joint is way down low. Okay, go.
OK， 如果它的 probe 刚好在它的 tibialis anterior 的这个 tendon 上面的话呢，你在它的 probe 旁边你进针呢，你会砸到它的 tendon 的机会呢就减低了很多，并且呢，如果你要打 tibia 的那边或者 talus 那边的话呢，也不要碰到，不会让它的 cartilage 受伤。但记得呢，就是打针的时候呢，整个 fat pad 一定要升起来。如果升不起来，你的针其实没有在 joint 里面，你的针其实在 extra synovium， 那就代表说你的那个硬骨根本进不去。
Unfreeze. So the next thing I'm going to do is I want to look at the retinaculum and the extensor hallucis longus tendon, because so I went from the posterior tibialis or anterior tibialis to the extensor hallucis longus, and you can see the thickened retinaculum over the top of it. And then and that's still the muscle, the extensor hallucis longus. And then if I move a little farther forward, the secret to getting, there's the artery for sure, but the secret to getting the digitorum is to move the third toe rather than move one close to the big toe, because that'll make the brevis move. So I'm just going to move the third and the fourth a little bit. Go.
extensor retinaculum 的话呢，让你如果你要 differentiate， 要分它的 extensor retinaculum， 你要动它的extensor hallucis longus 那个 tendon。然后呢，如果你真的要去 differentiate， 要去分到底哪个是 extensor hallucis longus， 哪个是 extensor digitorum longus 的话呢，最好你要动第三个指头，因为呢，如果你脚趾你只是动它的第二个脚趾的话呢，很难分。 动第三个你就可以分得到。
Unfreeze. So now I'm going to go back to the anterior tibialis, and you can see the anterior tibialis, and you see the joint move down below. then I go to sensor pollicis, you see it move. I get over to the artery and the nerve, and then I see the digitorum. And then the last thing I want to do is I want to go to a muscle that's lateral, and then that's going to be your quadratus. So your peroneus tertius and peroneus quadratus are going to be on the anterior side. So it's going to be, you're going to see basically a muscle that goes, because that's going to flip the side of the foot. Freeze.
然后如果要一直向外侧走的话呢，最后你可以看得到的肌肉呢，可能是 peroneus tertius 或者 peroneus quadratus。
And I think basically if I go do that other one, they can see from over there. So I'll do the medial one on this side.
现在我们到 medial side。
Unfreeze. Okay. So now we then gain up a little bit. Yeah. So now you can see the flexor hallucis is moving, and the tibial nerve, point to the tibial nerve, and then you can see the digitorum is moving over there, and then there's the posterior tibialis. And now what I'm going to do is say, you can see the tibial nerve is right there, but the mistake people make is they see the flexor hallucis tendon over there and think it might be a nerve as well. Okay? And now the most important thing I'm about to show you is I'm going to turn the probe on the posterior tibialis, and when I do that, and you can see the angle of the probe down at the screen, that's not going to do it. I have to point toward the ceiling like that, and when I do that, now I'm going to get the posterior tibialis tendon to go. And then when I rotate through, then I should get the digitorum, and then if I keep flattening out, now I'm going to get the nerve and the artery, and then down below, can we have less resolution? Can I have more penetration? That's good. There, that's perfect. So now you can see the flexor hallucis there. The flexor hallucis is more muscle until it gets around the edge of there's the artery. And then there's the nerve. And there's digitorum. And then there's posterior tibialis. So the main thing is look at where the probe is. So you watch, as I'm not going to look at the screen, I'm just looking at that picture. So so you see how I'm sliding off the malleolus? So what I'll do is I'll put my thumb here to block the probe, so I won't slide off the malleolus. And then I can actually follow it with my thumb, helping guide me along the posterior tibialis until I keep using my thumb to scan with until I have that tendon all the way across to the insertion there. And then what's under, and then if I go back along that tendon and I'm using my thumb, can I have some click of depth, please? More depth. Okay. So you see where the posterior tibialis is. And then you see what's the bone down below? Talus or navicular? So the talus is down there, and between the posterior tibialis and the bone with cartilage on it is the spring ligament. And then if I spin the probe 90, I can see the tendon and then the ligaments below it. So that's your spring ligament there. I mean, we could do deltoid ligaments, we could do all sorts of things, but the main thing is that. And then as far as the tarsal tunnel is concerned, I'm gonna go to the abductor brevis here, and you can see it insert onto the bone. And then just in the middle, there's a nerve, and that's Baxter's nerve. And then if I go this way, there's lateral plantar, and there's medial plantar. So my point is people are trying to find the nerves up higher, but if you get underneath the abductor hallucis, you can get them, and then you can move up, you know, but use that muscle as your guide to find it, and then I could go up, and you could see the nerves all come together, but there you can see them separate out. And now there's a muscle underneath the tarsal tunnel. This is the tarsal tunnel. And that one muscle just in the middle, that's the flexor hallucis. You can see if I move his big toe, you can see the flexor hallucis. And then medial plantar. So hit freeze, please. So now when we go to do a hydrodissection, that subsentaculum tali, I want to hit the tip of that right next to the medial plantar nerve. And that's how I'm going to hydrodissect the tarsal tunnel. And if I can't get all the way to Baxter's nerve on the far right side, then I'm going to have to go back in and poke it a second time to get it over, get that Baxter's nerve in the tarsal tunnel there. So, and you're going to do a lot of this and fix the neuropathies on the foot with that. So so that's tarsal tunnel, and now let's see. I can go with this foot now. There we go. Now you can see I've got, and I'm going to go that way to get the Achilles tendon is there, right? So I'm going to go back, and then right between the Achilles tendon and there's going to be some nerves, right? So you're going to have your sural nerve is going to be sitting right in the middle of the screen, up into the right there, and now we're going to hit freeze. And so you think of it, at least in English, I go peroneus longus, peroneus brevis, brevis for bone. Because that muscular branch is the brevis, and the longus is over there. And then I have a picture of the posterior syndesmosis between the tib and the fib ligament here. And with high ankle sprains, the front tear is bad, but when you tear the posterior syndesmosis, you're probably going to have surgery because you're just going to have a totally unstable, foot. So unfreeze. So now what I'm going to do is I'm going to show you again. If I spin the probe and look at, can we put the camera down just a little bit? There. Okay. So the bottom line is yeah, you can go to the back of the machine. We're good. But you see that if your brain would be doing this, but I want to go underneath there, and I could even use my thumb again. And now there's both tendons, and I can actually follow that one tendon with my thumb. And if you look, I'm moving both hands at the same time. So I'm trying to get enough gel around this. So, did you break this or sprain it, or what did you do to that fit? Nothing? You what? Track and field. So he's got a big swollen malleolus on this side. So yeah, so you can see the tendons. And then I'm just going to try and follow that one tendon down, and then you'll see that tendon is going to go under his foot, so that'll be the longest. And now if I pivot this way, I should be able to pick, there's the brevis. So look over at the video so you can see what I'm doing. I'm on the brevis, and I'm pivoting down. I didn't really get it very well. There it is. So there it is. So that's, and look at the video, there's the longest, and then this is going to be the brevis, going all the way to the base of the fifth. So what I'll do is I'll go to the base of the fifth, and now do you see, let me get that tendon better. There's the tendon better, but Can you see the head of the base of the fifth, and then there's a joint right there? Hit freeze. And explain to them how that mimics stress fractures.
OK，如果这边它的拉力很厉害的话呢，这边其实可以有 stress fracture， 就是它有个那种压力性的骨折。然后这边的压力性骨折的话呢，那个病人他这边其实也是很多时候呢我们会 miss， 但是dynamic ultrasound 也可以找得到他的压力性骨折，并且病人这边这种导管可以看得到他的neurovascularity， 发炎。
So now what I'm going to do is you're not going to be able to see it with the video because it's not pointing at the bottom of their foot. But what I'm going to do is I'm going to set the probe down on the bottom of their foot, this foot. So you can see that what I'm doing is I'm trying to line up on the proteus longus. So you can see that I'm not straight, I'm going down because the proteus brevis is going to grow on the proteus tubercle. And I'll set down on the foot and then I'll see if I can see that tendon going at the bottom. So there's
它是斜斜的呢，可以看得到 proteus longus 的 tendon， 到了 first metatarsal base。
And now hit freeze again. So we're getting a little shadow off the medial plantar nerve as part of Baxter and part of the knot of Henry. But just below the proteus longus tendon, just below it, you're going to have the Lisfranc ligaments. And so once you get good at this, you'll be able to get more penetration and dig into their Lisfranc ligaments and test them underneath that proteus longus right there. So that's that guy. Now, I saved it for last. I'm going to sneeze. So the most common ligament in the body to be torn, is going to be the intertalofib ligament. And I want you to look at this. The secret of that is I'm going to set it on the malleolus and I'm going to head toward the big toe on freeze. And now you can see there's the ligament. And now you know why I asked him whether he sprained or broke his ankle. Because he did. He just didn't know it, but he did. And that's why I saw this big lump here. And so that it's calcified, but it's supposed to be look like that. That's a normal ligament on that side. That is not a normal ligament on that side. You can kind of see it, but it's calcified right there. That's why his malleolus is bigger, because he fractured that styloid and calcified that ligament. So now the other thing is, another paper towel. So I want the second most common ligament to be torn in the ankle, and that would be the calcaneal fib ligament. And so what I'm going to do is I'm going to dorsiflex his foot, and I'm going to invert his foot. Then I'm going to put the probe next to his malleolus, except for I don't have no gel. And now I'm going to look for that ligament. So that's proteus there. Okay, try and let me do it. Okay. He's got some calcified spurring stuff, and you can see that his subtalar joint is hypermobile, and the ligament does not exist. He's got a little bit of it where that's fracture is, right there. But you can see that he had a subtalar joint, so he's torn the calcaneal end of his calcaneal fib ligament, and right there. So we're going to have a hard time finding a normal ankle in this room. No, at least on the model side. So the two ligaments that you need to do, the anterior talofib and then the calcaneal fib. And then I showed you the syndesmosis on both sides. So we've got that. So what we're going to do is we're going to clean him up a little bit. I got it. Hold that. Okay. All right, perfect. So now when you do the Achilles tendon or the posterior, you want to keep the dorsiflex so that you don't have that tendon that's going to be folding. So I'm going to stretch it out, and then I'm going to look at its insertion, and then I'm going to go into the back here. I'm going to look for, there, okay. And a little more, one more click of depth. I need more depth. More depth, more, there, okay. So that bottom you can see is that's going to be his flexor hallucis muscle there. And then what's the name of that fat pad? Kager's fat pad?
如果要考试，记得哦，这个 RMSK 这个一定有这样的问题。
Then can you see his retrocalcaneal bursa kind of roll a little bit right there? Okay. And then do you see the little spur there, and then hip freeze? Do you see how hypoechoic the insertion onto the calcaneus is? I'm a little surprised, but there are many tendons in the body that insert onto hyaline cartilage, and the Achilles tendon inserts. It's the hyaline cartilage insertion onto the calcaneus. So that's not just anisotropy, that's actually hyaline cartilage in the tendon insertion. And there are, I think, 12 tendons in your body that all have hyaline cartilage, but that's one of them, and the retrocalcaneal bursa there. So unfreeze. Now I'm going to go short axis, and then you can see the spin of the Achilles tendon. And now we're going to go and we'll see the little bursa, and now we're going to look for that spur, and there's a little family of spurs right there. Okay, so that's going to be Achilles tendon. I'm going to go back long axis, and I need more depth. More depth. Okay. So yeah, and there we go. So yeah, so now we've got that Achilles tendon, and then you can see the soleus is joining the gastrocs. Now, show them right at the top of the surface, right there. So that's the plantaris. So it's on the medial side of the Achilles tendon, it's on the lateral side of the knee. So the plantaris is right there. It's a little tiny round thing. And it's actually, once the gastroc turns into a muscle, it's going to go between the gastroc. And there it goes. Now, there's the gastroc muscle, but there's the plantaris. All right. Now, can you see the joint in the bottom? Has a talotib joint down there? And what's that thing sticking up in the air over to the right? Os trigonum. You want to tell them anything of this?
Yes.
Hip freeze.
这边呢有块骨头啊，这个 os trigonum 这块骨头可以有 fracture 啊，然后 posterior impingement，因为其实也蛮常见的。
And by the way, you are not born with an os trigonum. It is a developmental mistake that we all make by make our children walk too soon. They've done the study enough that all the kids that like the cerebral palsy and the non-weight bearing children don't have an os trigonum. So we develop an os trigonum like we develop a suprascapular notch. We don't have a notch when we're born. The omohyoid pulls that part of the scapula to form the notch. So those are developmental, just FYI, because some people have bad os trigonums and they're trying to play soccer when they're adults and they've got problems. And part of that was because they started walking too soon, or they were forced to walk too soon. You can explain that.
这个骨头呢，其实是 developmental 的啊，因为我们可能太小的时候呢，太早开始走路，然后呢就慢慢就这个肌肉呢一直拉，就最后变成一个 bony prominence， 就变成一个骨头，就好像我们的那个 suprascap 跟老师一样，就我们还有那条肌肉一直在拉。他们做了一些研究的话，那些小儿麻痹的那些病人，或者是那些病人他没办法走路的那个小孩子呢，是没有那个 os trigonum。
And then, and I think the last thing that I should do is just make sure you've got the plantar fascia. And so you'll see that I'm going to line up on the plantar fascia here. Take the gain back down.
看见确实也最确实。
That's better. Okay. So there's the plantar fascia. And this is the secret, right? What I'm about to do now, I'm going to roll the fat. And that gives you an idea where the surface of it is. So you can use that technique to find out where the real surface of that plantar fascia is. And so now hit freeze. And now let's measure that. Okay, how do we measure? All right, then hit set. All right, now you can see the size is 3.7, and I published 2 papers on that, so I'm pretty well versed at it, but 4 millimeters or greater is defined as plantar fasciitis. Now, now I need another measurement, please. Okay, hit set. So there's 7 millimeters. You can see that it would be a lot different. You should see that pretty easily. So just so you know, 4 is max, 3 is normal. After a marathon, a normal foot would go to 2. They would get dehydrated and thin. A plantar fascia in a marathoner who starts out at a 5, which is more than a 4, will go to a 6. And a 6 before a marathon will go to 7. And out of the 25 plantar fascia patients that I had, the two 7 millimeter plantar fascia patients, both ruptured in the marathon. So it tells you that if you're at 6 or 7, it's either ruptured or it's gonna rupture. Now, so just, to realize when you put the probe down and they've got a 7, no wonder they can't get out of bed in the morning, because it's either ruptured or gonna rupture. So that's plantar fasciitis right there. Anything else, Stan, that I might have missed? I think we got through it pretty good. Of anything to remind you, ATF, malleolus to big toe, calcaneal fib, dorsiflex the foot and invert the ankle so you can line up on the fibula to see that ligament that he didn't have. And then when you go to the posterior tibialis or you go to the peroneus tendons, remember you're not gonna go sideways, you're gonna go basically behind the malleolus to look at the tendons and the nerves and stuff. And then Achilles tendon, you wanna keep the foot dorsiflex so the tendon is nice and long and linear. And then with plantar fascia, you wanna roll the probe to have the fat move to give yourself a chance to see the surface. Okay, go, 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 go.